Perfect. Well, good morning, everybody. Welcome to our presentation. So excited to be here with you today for infant and early childhood mental health intake forms. This is a little overview of how we're going to spend the next hour together. Christina and I are going to do some welcome. We're going to provide a little background on what brings us here together today, and then we will get to the best part of today, which will be our provider spotlight. We have three amazing panelists joining us who are going to share a little bit about their experience. If you have any questions at any point during the presentation, please feel free to drop those in the chat. And here's our welcome. So if we haven't met, I'm Kiki Fabian. I work at the Healthcare Authority, or HCA, which is our state's Medicaid agency, as well as our Behavioral Health Authority. And I have the great pleasure and privilege to focus on infant and early childhood mental health programs. And I'm joined today by my colleague, Christine Cole.
Hi, everyone. Christine Cole, she, her pronouns. My background is as a clinical social worker, and now I get to apply my experiences in the field, working on infant mental health with Kiki, as well as some other stuff here at HCA. Glad to be here.
And we also want to get to know you. I see folks are already starting to do this in the chat, which is awesome. But we'd love to know who you are, what you're all about, maybe where you work, what you do, and what you're hoping to get from today. We know that people are here from a lot of different backgrounds, have a lot of different things that they want to learn or even share about. And so knowing what brings you here today helps us make sure that this information is useful for you. So just want to say a quick welcome to Marisa, to Sherry, to Justin, to Deb, to Bridget, everyone else who is here today. We'd love to get to know you and learn more about you in the chat. And it wouldn't be an HCA presentation without a couple of updates before we dive in. We wanted to share two kind of interesting pieces of information that are new and I don't know, hot, let's say, they're going on right now. So one is that we're going to be talking today about a set of policies called mental health assessment for young children. That's kind of what brings us all together. We'll do some background and then the panelists will talk about their experience with it. But we did have a recent report that was published looking at the impact of these policy changes on practices using medical claims data. And we found some really positive impacts on practices and outcomes for children and families. So we'll make sure that you all get the slides and the links to this, but would really encourage you all to read that report and to celebrate with us the progress that's been made in our state. The other update that we want to share is that the DC 0 to 5 is a diagnostic manual for diagnosing mental health and developmental conditions for young children. You'll probably hear more about that in our background and on our provider panel today. But HCA, as part of kind of the MACI, or the Mental Health Assessment for Young Children implementation, we published what's called a crosswalk. That connects DC 0 to 5 diagnoses to ICD-10 codes, which is what people need to use for health insurance billing. And so every year we offer an opportunity for the community to provide feedback and review of the crosswalk to say, is this working? Is this the right code? Have we got everything we need? Is there additional information that needs to be included in the crosswalk? This, I believe, will be our third time doing a community review of the crosswalk. So we're really getting in the groove now. And we would love to have the community's feedback and perspective on things. And yes, great call out, Christine, that Haruko was one of the members of the initial work group that put the crosswalk together. So that is really exciting that she's still part of this work with us. HCA does have a few proposed updates for this year, and so you can check those out in the materials. That will make sure you have the link for that as well. And we'll just flag that we started the feedback process October 1st. We will be closing feedback November 1st. That helps us make sure we have something final to publish January. But we also have a form embedded within the crosswalk that people can give us feedback at any time. So it doesn't have to be during this period to give feedback, but this helps us to create, an update on an annual basis. Any HCA update stuff that I'm missing, Christine, or anything you would add about these two? Okay, perfect. All right, well, let's dive into some background. Why are we here? What's going on? What the heck? What's happening? All right, so I alluded to this a little bit already. Mental health assessment for young children. We call this MACI, like the department store. It's basically a set of policies that changes how Apple Health or Medicaid reimburses and guides providers when they're doing a mental health assessment or an intake for young children. There's three parts to this. One is about reimbursing folks for multi-session assessments, so meeting multiple times with the same family to do that assessment to come to a diagnosis if there is one. Allowing reimbursement for provider travel when assessments happen in the home and community, and then requiring providers to use the DC 0 to 5, which is that developmentally appropriate diagnostic manual for young children. And so these policies all went into effect in 2022. And this slide kind of shows a little bit about why these pieces go together. So when we think about the DC 0 to 5 as a diagnostic manual, and you'll probably hear a little bit about this today, it's multi-axial, which means it has these different components that really are needed to fully understand the developmental and relational pieces that are going on in a young child's life before coming to any sort of conclusion about what we call an Axis 1 clinical diagnosis or mental health or developmental disorder. And so understanding all of these pieces can take a long time. It's often best done in settings where you can really understand the child's behavior, the parent-child relational context. And so that's why these MACI policies are helpful, we hope, in helping people to kind of step into this developmentally appropriate practice. Oopsies, too fast. But we know that sometimes policies are, well-intentioned, but do they actually work out? We'd like to check in with folks and see. And so 2 years ago, we went around to each region of the state in partnership with all these wonderful folks on the slide here today to really ask providers, like, how is this going? How is it working? Are you making any progress? We talked to almost 100 different providers from over 50 different organizations and gathered a lot of great feedback. And one of the things that we heard from folks was that they needed more around implementing mental health assessments for young children. So they needed more education, they needed more support, and they really raised a lot of operational things that needed to be put in place at their agency in order for this to happen. So it's not just going to the DC 0 to 5 training and then you're good to go. There's all these other pieces to put in place. And the other thing that we learned from the statewide tour is that providers really love to learn from one another. It's really great for HCA to put out resources and guidance, but what was really beautiful that we saw on the statewide tour was different providers sharing with each other what they learned from their experience. Not only the wins, but also what was hard, what was maybe more of a struggle, and that really creating a sense of community and bringing people together. And so that inspired the Spotlight series that you're attending today, where we've had different providers serve as panelists talking about their experience with these different pieces of implementation. On the screen, you'll see the last four that we've done. All of these we either have slides or recordings from, so if any of these topics are speaking to you, we'll make sure that you get the links to learn more from these past spotlights. And with all that being said, I think it's time to dive into our spotlight. Anything I'm missing, Christine? All right. Well, I'm going to stop sharing so that we can focus on our panelists. And I'm going to do one thing before I get started with questions, which is I'm going to try to spotlight our panelists. Okay, I think I've done everything. Does everyone see 4 people now? Wonderful. Okay, great. So let's get started with our panelist introduction. So we're going to start with Haruko, then Laura, then Haley. And if you could share a little bit about you, about your program, and the why for you. From your perspective, why assessment and diagnosis for this age group matters. So Haruko, I'll turn it over to you.
Thank you. Good morning, everybody. My name is Haruko Watanabe. I use she, her pronouns. I'll say I'm a cisgendered woman of Japanese heritage, an immigrant, parent of 2 children. I'm the clinical director at Coupa House, which is an infant and early childhood mental health program, a clinic in Seattle with a team of early childhood occupational therapists and mental health clinicians on our team. We get to look at children's development, their relational strengths and challenges, and their experiences in the world, in all of their in their social cultural contexts. I enjoy having the richness of multiple perspectives on the team, and to be able to think deeply and complexly about what it's like to be a young child. Right? So that's the program that I support. The quick why. Maybe I'll lean on a little bit more on the assessment portion. I think the assessment is so critical because it's our way of understanding how the client family got to the place they are at, right? When they are seeking services with some sort of identified issues. There is the assessment for the purpose of diagnostic formulation versus there is assessment for the purpose of clinical case formulation that are a little bit different. I know we may not necessarily get into the details of those distinction today, but I just wanted to name that those things are not the same. So there's that. I think organizations and systems can do client families and clinicians disservice when they restrict clinicians' ability to use tools and processes that are best practice for serving young children and families, and insist on standardizing assessment process to using what was built for older children and or for adults, or insisting on standardizing assessment processes that was using those processes that was meant for older children and adults. So organizations and systems, level, we can set the clinicians up for success when we provide enough time and support and learning opportunities to get so for all of us to get skilled assessments through building knowledge specific to early childhood mental health, and help them build and practice using critical thinking skills, which I think is really, really important in assessment, to gather information that will be useful in ongoing intervention with client families. I'll pause there.
Thanks, Ruko. I especially love what you said about assessment as this opportunity to really get to know the family. I saw a lot of head nods when you shared that of like, what really is going on that brought them to meet with you and to be in this relational space together. And I think that's really beautiful. And then also to your point about, agency decisions about standardized processes. We'll get a little bit more into that later, but that's really a key question from many providers when they start to work with this age group and are trying to do things in a developmentally appropriate way. So thank you so much for sharing. And I will pass it next to Laura to introduce herself.
Thanks. So my name is Laura Scrotenmore. I use she, her pronouns, and I am currently in private practice in Spokane, Washington, although have worked in community mental health settings, both as a clinician and as a supervisor. So I've kind of had the experience of both sides of that. In my current practice, I work mainly with young children. We have, there's 5 of us there, and we serve the entire lifespan so that we can have parents seen in the same place where their kids are seen, so that we can all just kind of work together and coordinate, or for older kids, so parents can be seen while their kids are being seen, to try to make it a little bit easier on parents. But ever since I've started in this field, I've worked with kids and have loved it. And as I've worked at different agencies, I actually saw a lot of places were turning away kids under the age of 4 because they either didn't know how to do an assessment on young kids, or the perspective was this is the parents that need the treatment, not the kid. What are we going to do with a 4-year-old in therapy? And so worked with agencies I had worked with to say, hey, we really need to work on this. We need to bring these kids in. There's a lot that we can do because, as we all know, early intervention is the best. And so if we can bring them in and we can help mitigate any risks early on, we're setting them up for a better future. And so, like Haruko also said, I also have seen families be kind of hurt by the assessment process when assessments are meant for older children or adults, and we're not seeing that match up. And so that's kind of why I became so passionate about this, is to make sure that we are helping these kids and we are doing these families the best that we can instead of kind of having that harm. And I still have kids come in where parents are kind of hurt by previous assessments where they felt like they weren't heard or understood. So yeah, I think that's really where my passion for this comes from.
Thanks so much for sharing, Laura. I think, this a little bit ties into what Haruko said of this really valuing the family experience. And I think that's a narrative that we unfortunately hear often as well, that when there's this mismatch between what the service is and what the family needs, that can often create a ripple effect of kind of like reinforcing feelings of isolation or like systemic barriers to accessing care. And we've also unfortunately heard what you're sharing about many different agencies not necessarily serving young children because they are either not understanding that this can be an area or not feeling prepared. And so we know that Washington State, at least, young children with mental health conditions are less likely to get access to care than older children. And so we think it's really important to focus on this area as a disparity to address. So appreciate your passion and the way that you're showing up for families. All right, Haley, would you like to introduce yourself?
Good morning. My name's Haley Johnson. I moved to Washington in 2020 from the Iowa-Nebraska area where my journey working with children and families started. I'm just going to give you guys a heads up. I'm super passionate about working with what I call littles, the kiddos for this age range. So I speak with a lot of excitement. So just want to give you a heads up at the beginning. I am a child and family therapist working at a local community agency, mental health agency. We're located in Tumwater, Washington, but overall, our company has 12 children and child and family programs. Our agency serves thousands of children and families. Specifically for our program, we serve children 0 to 21. And we are across the Western Washington, and we serve individuals who have Medicaid benefits. So why I think the assessment and diagnosis process is vitally important. I mean, the first few years of a kid's life are just incredible. I mean, their brain is developing so quick, making connections that set the stage for everything from language to learning, emotion regulation, relationships. It's also when we first start to see the signs that something might be just like a little different. Maybe a delay in speech, challenges with attention, sensory sensitivities, or social interaction struggles. And sometimes our caregivers are like, what now? What do I do? Like, there's so many things out there, but where do I go? Where do I start? And sometimes I hear frustrations of you get sent from one person to the next agency, and there's a lot of frustration. And sometimes caregivers are like, well, what do I do? Even goes to terms of this. So like, what do we do? Who do we need to bring in for the support for this one? So when we diagnose early, we give those kids and their families a huge advantage. We're not putting a label on them just to categorize them. We're giving information. We're giving understanding and direction. We're opening the door to services, supports, and strategies that can make all the difference. And we've seen it all. The toddler who starts speech therapy and suddenly blossoms. I mean, how about the preschooler who gets behavioral support transitions and then is able to transition to kindergarten and more successfully? It changes family stories. Without early assessment, so many kids slip through the cracks. I mean, their challenges might be misinterpreted as behavioral issues or learning problems, when really they're just signals for supports. So at the end of the day, early assessment and diagnosis is about giving every child and family a fair shot at thriving. They're about prevention, empowerment, and hope. Every early screening, every careful evaluation, I mean, every conversation that we have with these parents, it all matters. Because when we start early, we don't just change developmental outcomes, we change lives. I want our kids and families not just to survive in life, I want them to thrive in life. And giving these tools in DC 0 to 5 protocol to clinicians who can utilize it to set these families up for success, I mean, it's huge. I think most agencies, at least I know ours, aren't set up for evaluating little kids. I often hear clinicians are like, I don't want to work with the little kids. I don't know what to do. And we need to empower more clinicians to say, hey, here's the data. This is vitally important. Here's a standardized practice of how to utilize these tools. Let's try it out, formulate it, work with it, change the flow that works for you and within your agency, within yourself as an individual clinician. Here are the tools. Let's use them.
Wow, Haley, I feel like we should all like have a little round of applause for that beautiful share. That was amazing. Feeling very inspired and touched. And like you said, you are very passionate about this area, and that just comes through in your words. And I appreciate you raising this kind of tension that we're often in of like, okay, is diagnosis going to be labeling, stigmatizing? Is it going to provide information and access to services? And we all have to come to our own conclusion about where we lie in that tension. But I appreciate you kind of elevating the value that can be available to folks with more information and access to things. And what you closed with, I think, circles back to what Haruka started with, and it's going to be kind of our deep dive topic for today. So, for folks who may have worked in different mental health practices or may not, usually what happens when a family comes in is we start with this intake assessment process. And depending on the setting where folks work, they might have a standardized process that everyone in their practice or their agency follows. And this might look like a manual, it might look like a packet of forms that gets handed to you, it might look like a structure in your electronic health record or EHR. It might look like this is what we do at each session, or it might just look like the culture of the organization. Like, well, this is what we kind of do, and this is what's normal, even if it's not written down. And for many folks who are working at organizations that are used to serving adults, adolescents, or even older children, elementary school age children, the process might not actually be quite the right fit for young children and their families. And like what Laura shared, like that can sometimes be, damaging to families in terms of the relationship. And it also might not get clinicians all the information that they need to accurately assess and evaluate what's going on. And so we've heard a lot of questions from folks about like, okay, I hear what you're saying that maybe what we have is not quite the right fit and that this needs to be tailored to the child, but like what does that look like? How do we do that? What does that process look like? And we do want to caveat this to say, like, in Washington state right now, there's not like a required process that people have to follow. And so there is a lot of flexibility, freedom, and autonomy that organizations have to define what this looks like for them. So, what our panelists are going to share is not like, here's what you have to do. These are more examples and perspectives from their own personal work that we thought would be valuable to share with the group. So with that being said, we're going to take a slightly different lens for each of the panelists because they bring different gifts and strengths to these roles. So I'll have different questions for each of them. But if we have time, they can, just reminding our panelists, you can also ask questions to one another or reflect back what you're hearing. And then audience members, if you have questions, please feel free to put them in the chat and we can raise them to the panelists as well if we have time. So let's dig in. Laura, you are, I don't know if everyone knows this, but you are a DC 0 to 5 trainer. So you're certified to train others in using the DC 0 to 5 diagnostic manual. This question that we're kind of wrestling with about, intake forms, intake processes, is this one that you get often as a trainer? And how do you think about it and approach it in your own work?
This is honestly one of the most common questions that we get in the DC 0 to 5 trainings. We go through the manual, we teach these clinicians how to create this diagnostic process, how to think about a diagnosis. And then at the end, they all say, okay, so now what? How do we actually do this? Like, this was great. Now we need to implement it. And it's really hard when you then have to take it back to an agency where there are set forms, policies, procedures, and a lot of kind of red tape that they have to go through, or even upper management that might not understand what it's actually like working with young children. I've actually worked with a couple of intake specialists in our area to say, okay, how can we bring this back to your agency? What are some maybe small tweaks that we can make to your current forms so that it is more appropriate for young children? Thankfully for myself, I am in private practice, so there is a lot less of the policies and procedures that I have to go through to make some of these changes. But what we did do is the therapists that are at our practice, we kind of sat down together and said, okay, how are we going to make this work? So we redid our forms. We have specialized form for under 5 years old that focuses on all of those aspects of the DC 0 to 5. So asking questions about culture, physical health, the stressors, and some of those developmental questionnaires. We also made sure that all these screener questions were age appropriate, and as minimal as we could get. Thankfully, my husband, I felt bad for putting him through the ringer, but I was like, hey, try to fill out these forms while watching our kids and tell me what it's like. And he did. And he was like, okay, these questions are redundant. I only want to answer this once. I'm like, great. And so we really took a deep dive look, practicing it ourselves, seeing what it was like to really make sure that we had a good assessment. All of our clinicians were also trained in the Marshak interaction method to do that relational look. And trying to then also focus on this balance between strengths of these families and also areas where maybe they need a little bit of help, so that when they were coming in, we could talk about, here are all the things that you're doing great. This isn't anything that you did wrong. These are just challenges that are coming up. And here's what maybe we can do about it, so that they were also feeling seen and heard in that process, instead of this guilt as parents of, maybe I messed up somewhere. So we're still constantly kind of tweaking our intake process, because we're finding maybe some things could be a little bit better, or maybe we could shorten this or add that. So it is always a balance. And as we know, parents with young children are busy. And if we are all honest here, nobody likes doing a ton of paperwork. So we are constantly trying to find that balance too, of how can we make this the most approachable. But yeah, I think our biggest takeaway was framing challenges in digestible ways for these families, and also instilling in these families a sense of resilience of, you guys are doing hard things, you are coming here. We have also made sure that we are able to go to either daycares or schools for these kids to try to see what's going on in those areas, and really utilizing the multi session intakes. That has been super, super helpful. We just need to get private insurances on board with that. That would be great. But it has been so helpful to really be able to take our time so that we can have this really good balance for families.
Oh, Laura, that was beautiful. Thank you so much for sharing. I just want to call out what you shared about, framing challenges in digestible ways and also highlighting resilience. This is something Christine has really taught me, is that, assessment can also be intervention, that the process of assessment, while, we're gathering information, we're trying to understand things, it's also an opportunity to be in relationship with families and to make sure they feel supported, empowered, and that we're kind of starting the process even of addressing things that may be challenging or may feel hard in the process itself, especially when you have a multi-session assessment where you're maybe meeting over the course of a few weeks. There's so much opportunity for relationship building and holding in that period. And also just want to share, I actually didn't know this, I'm learning this now, about how you kind of road tested your intake forms, not necessarily with the client, but with someone who is thinking about what is it like to do this as a parent. And I just think that's incredible, and really want to call attention to that as potentially something, a best practice that others could utilize as well, to say like, well, what is it like to do this and how might we adjust this based on the feedback of someone who's not taking the perspective of a clinician, but is taking the perspective of the parent, the client, the family. So thank you for sharing so much about that. All right, Ms. Haley, I'm sure that there are pieces that you heard in what Laura shared that resonate with you. Can you tell us about your process to adapt, work with the intake form at your agency, and maybe a little bit about what your current form looks like?
Yeah, definitely going to piggyback off of Laura with that. We just took this amazing training, given the tools. So now it's like, what do we do with the tools? How do we implement it too? Because not all of our agencies or private practices are the same or utilize the same assessment template. So I had to kind of creatively come up with a way to get these evaluations put into our mental health assessments so that they can be documented. Way our agency does mental health assessments is they're scheduled for a 2-hour intake in office. I mean, 2 hours for little kids, rough. I mean, I got toys, but still a long time. So I've been given the opportunity to schedule for more appointments to complete the whole assessment. And I actually section each evaluation out into separate appointments so that I am able to gather more information and do more observations too, and even give some opportunities for like teachable moments, providing psychoeducation too, as we kind of go through the assessment process, or identify necessary supports and get referrals out for supports as we go through the process. So all of our evaluations are in office. We don't have the opportunity to go out and do observations for little kiddos. Our agency doesn't work in the elementary schools. We do in the middle and high schools. So we don't have that ability, but we do have the ability to collaborate with the kiddos' other areas of life. So if we need to talk to doctors, if we need to talk to the Department of Children, Youth, and Family, if we need to talk to schools or daycares, we can collaborate out and get some more of that information. So I broke down each evaluation to make it flow better for me as a clinician, and so I can provide the best information to put into our mental health assessment. So as I also had to look at what our mental health assessment framework looks like, and I had to say, okay, I got all this information from the evaluation. Where does it go? Where does this fit in? Where does it flow? Where does this information need to be put in? So I had to create my own fillable forms, which I absolutely love to do because for my brain, it works for me to have fillable forms that I can copy and paste into our mental health assessment. I'm all about efficiency too. So the first one with the psychosocial stressors, I had to figure out where am I putting this in my assessment. So I chose the area of trauma, abuse, neglect, anything in life. When I do that evaluation too, I also kind of crosswalked it with our ACEs and the CATs. So in which they both fill out prior to the assessment. So if they give me those documents, I can look at the DC certified evaluation, and I've put the questions together. Where does this CAT's answer match up to a question maybe from the psychosocial stressors, right? I also recategorized it so I can have a more conversational flow with individuals. So I kind of put questions in certain topic areas in chunks. So it wasn't just me asking a question, getting an answer, write it down. Me asking a question, getting an answer, writing it down. It's more of a back and forth. And sometimes it would prompt additional questions. So I wanted to make it more of a natural flow because sometimes our caregivers are kind of like nervous with this stuff. And we want to make sure that they're feeling comfy and cozy. And same thing with our kiddos. We want to be having age appropriate questions, kind of like what Laura said, that are short, simple, and that can get us enough information and collaborating with other supports. The same thing. So the next one that I do is the physical health conditions. We have an area in our template that covers physical and dental health. And I was like, this is perfect. This is where it goes. I also created a fillable form from the assessments so that I could fill out the information, copy and paste into my mental health assessment. But I recategorized things. I put in examples of medical conditions, of concerns, so that I could better encapsulate all the information and physical well-being of this child. Also with these, could it flag me a concern? Do we need a PCP? Do we need a dentist? Do we need other medical providers too, right? I created it to a way, say, hey, tell me what your strengths are. Let's identify the needs, and then what are the supports for those needs? So that's why I kind of section them out so I have opportunities to kind of go through that flow with each assessment. The developmental competence evaluation. I also created fillable forms so that I can write more information in it. So I can type it out, copy and paste it into my mental health assessment. I also crosswalked it with the ASQ assessments that often little kids are getting done when they're in like daycare. So sometimes parents already have an ASQ filled out, so I'll ask for their most recent copy, or I might provide it. And again, sometimes ASQ questions give me vital information for the developmental competence. So I'm spending more time observing, working with the kiddos and families than so much just being focused solely on just answer or question, answer, fill out my form too. I'm trying to get more engagement, conversational flow. And then the same thing with the relational context too, fillable form. I kind of categorize it into a natural conversational flow, age appropriate. Also, I use a short sensory profile to help me with the children's relationship and how does their sensory experiences interplay with the relationship with their caregivers. Even added maybe a short like parenting assessment and identifying the parents' needs and their parenting style and how that impacts their caregiving relationship and the relationship with the child. So everything I make is fillable. And then I have a template that I copy and paste into the assessment, and I just put my answers right into there. So it's standardized. So every little assessment that I do, if you go to the trauma, if you go to physical health, it has the same template with all the information from that client's assessment. So I wanted to make it efficient, not only for me, but for the clients I work with too. So it doesn't feel like question, answer, it's conversation. Make it collaborative, grabbing collaborative information from other providers and supports, and then teaching in the moments if I can, and then also providing supports at the end too. Like, hey, I think we here have an identified need. What support can we connect you with? Who can we refer to you to have like maybe that specific need met too? Occupational therapy, speech therapy, parent support classes, right? Do we have to do a higher level of need referral? Like there's so many options out there. Can I support you as we assess so that we can have these other supports and work together as a team?
Well, that is beautiful, Haley. I think what I'm reflecting back is that you're working, within an organization that, like you said, has this mental health assessment template, this thing that fairly structured, and you're trying to figure out how do I, as someone who's working with this perspective of infant and early childhood mental health, fit my work within an already pretty structured setting. And you're also, I think, really bringing up what are some of these like operational tools that people might be really interested in, like fillable forms, like how do we just make this process easier for all of us. And also thinking about like, how do we think about the structure of this so that it feels conversational to the family? Because like someone put in the chat, forms feel like tests. And that's usually not an experience that most of us in life enjoy. And so how can we make the process feel less like a test and more like a service, more like a conversation, or like a relationship? And identifying, all those different parts of the DC 0 to 5, how you've mapped them on, and then how you're thinking about them, I think is a really beautiful example of what it looks like to do this work in a setting that maybe was not designed for it, but you're figuring it out anyways. So thank you so much for sharing. All right, Haruko, our last panelist. I'm sure you've heard lots of different things from Laura and Haley that are popping ideas into your head. What Haruko and I talked about kind of in our prep time is a little bit more of like the meta level of this, of like what comes up when you hear this, as this is, like Laura said, maybe the most common question that she gets as a DC 0 to 5 trainer, hearing from us that this is a common question. What comes up for you when you hear this question? And how might we take a step back and think about the why behind why this question is so pressing for many people?
How long do I get?
You can have 7 minutes.
Okay, I'll get going. I really appreciate Laura and Haley covering so thoroughly and thoughtfully all the pieces so that I can come to this, I can think about this piece, because I think there are pros and cons, and there is such amazing usefulness to intake forms. And in anything in life, the less I feel experienced in something, or the more dysregulated I am in the moment, the more I need to rely on something, right? So it makes sense that when organizations are trying to tackle this immense and overwhelming work in kind of customizing or tailoring their assessment process and their forms to be able to serve young children. So I think I just commend all of the organizations trying to do that and clinicians trying to do that. I think that's really, really amazing work. So thank you for all of that work. And I think the piece that I wanted to respond to is, in addition to the intake forms and the specific questions we may have listed on the forms, the place that I find myself going to with clinicians is like, what do you want to know? What are you curious about? I hear my mentor's voice loud and clear in my head that, remember, it doesn't matter that I've served 3,000 children. Every child is unique. Every family is unique, right? So every intake requires that level of seriousness, right? Take it seriously. This child will show up, this family will show up in ways that no other family has ever shown up, right? So there is that level of seriousness that requires all of us. So what do I want to know? What do I want to know about this child, right? So it is such an amazing resource structure, system level advocacy work that we have 5 assessment, because I can't imagine, I do remember how it used to be 20 years ago, 25 years ago. But it requires so many different opportunities, right? Like Haley was illustrating each assessment appointment hopefully allows us to gather information that we didn't have before. Hopefully those are going to be information that's useful, because the task of the assessing clinician is to be gathering information, but also developing multiple hypotheses all the time, right? So I know that my clinical training in early childhood field has taught me that, yes, it is my responsibility to be developing multiple hypotheses all the time. Come up with as many different possible hypotheses as, to explain this particular behavior, say tantrum, right? How many? But because I have my go-to, oh yeah, I bet it's that, right? Go-to guesses, but I don't know that, right? So to be able to come up with as many hypotheses and each assessment opportunity, each conversation with the client families allows me to come up with specific questions based on what I've already heard so far. Specific questions, not the questions on the form, specific questions that's unique to this kid, unique to this parent-child relationship, that will get me closer to either affirming or ruling out a hypothesis that I have, right? So it's those kind of things that's also important. So I know that that's a little off in terms of this question about the intake form. And I think intake form can help us cover all of the things, right, that we want to be covering, especially with diagnostic, right, assessment. For case formulation, I think it's a little bit different. So, what I just said about coming up with as many, specific questions as possible for this kid will be useful in case formulation because, like I said earlier, assessment is the process to get to hear the family story, right? It's really about partnering with family and co-creating the meaning with a family about what may be happening for this kid, right? In their relational context, social cultural context, right? So all of the pieces that Haley was talking about, psychosocial stressors, protective factors, medical concern development, all of it, right? All of those things are basic information that we want to gather, and the why behind clinicians asking for a specific form, we want some sort of guide, right? Where are we going, right? Do I really know, right? The more we get to know about in this field, the more we learn about. I'm learning a ton right now from our early childhood occupational therapist about things that I didn't know for 20 years that I've been doing child parent psychotherapy, right? So it's just the more I know, the more I know how to ask questions about interoception now in intake assessment that I'd never, how do I ask that question? I don't know, right? I just had, so I just don't want to let go of the need for all of us at the system level, organizational level, individual level to invest in ongoing learning, right? Ongoing, the more we know, the more we can get to refine the assessment questions, right? In addition to the form that will continue to guide our clinicians. I might be rambling, so I'm going to pause there to see if I'm getting to your question.
Ruko, you're getting lots of nods and heads up from the panelists. I think what you shared is a really beautiful, like reflective piece. And we all know that reflection is such an important part of the infant mental health field of thinking about what is it that I, as a clinician, what am I showing up? What am I bringing to the interaction? What are the needs that I feel like I have to do this work? And how do we navigate that balancing, like having enough supports that we feel safe, that we feel secure, that we can move forward, and also having enough openness and ambiguity and potentially lack of closure or certainty so that we're really open to like the relational emergence that might happen in the moment that no one can predict, because like you said, every single person, every single family, every single person family situation interaction with a different clinician is going to be totally different. And so the questions that are the most valuable may be the ones that we've never even thought of before, that no one's even thought to put down on an intake form. Another piece that I'm noticing that like a little convergence is the benefit of this kind of collaborative interdisciplinary work of Haley speaking to, oh, what are the different partners in the community, other providers, other sources of information that I can learn from that can inform my work. And then Haruko sharing that, really learning from other providers, not only the content, the information itself, but also how does their perspective, their disciplinary expertise then inform how we show up and how we approach this work. So I think that's another, key principle of infant and early childhood mental health is cross-disciplinary work together. And I think all of you have really highlighted that for the audience. We just have a few minutes left, so I'll pause and see if any of our panelists have any questions or comments or things that they want to build off of from one another. But if not, we do have a question from a special audience member, Christine Cole. All right, Christine, why don't you go ahead with your question?
All right, you guys left it up to me. I think maybe we can start with Haruko, but Haley and Laura, I'm sure you have thoughts on this too. As Haruko was talking, it was just making me think about us applying are concepts of infant mental health that we use with families, even for our providers and agencies, and this developmental perspective. Haruko, you did a nice job of talking about like, I might need more structure in the beginning, but I want to get to this other place. And so I'm curious, what you all think would help folks to be building their developmental capacity to be moving towards kind of being able to hold these new questions and to become more attuned to what the family is saying. And some of that might include having a form to help you along the way, but thinking about that developmental perspective of getting from this like, I need a form to getting to this place of like, oh, I'm wondering with the family and evolving as I go. How can we build capacity in ourselves as providers?
I'll speak to one specific thing that I try to lean into, which is capacity to not know, the capacity to be able to sit with uncertainty and discomfort in not knowing, not having the answer to something. How helpful it might be to reassure all of us clinicians that that is actually one of the infant and early childhood mental health competency that we are actively working on. While we work within systems that insist on us having the answers, does that make sense? So to fight against, right, that the pressure of having all of the answers, experts having all of the answers, best practice in infant and early childhood mental health is actually to be quite tentative, right? I'm not, did I hear you right, Dad, that you think da 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 da? I might have, or like, this may not be right, but a thought is coming to my mind, so I'm gonna share that. Can I check with you, like what's coming to my mind? That level of that kind of stance is the classic like infant and early childhood mental health stance, which is really different from intake clinicians internalizing this pressure to have the answers, right? So I think that piece is that cannot be highlighted enough, in my opinion, so that when clinicians feel uncertainty around like I don't know if this is right, the supervisors and supporters, the consultant, we can all support that clinician to think, oh, hang in there, right? Hang in there, hold. When we can be tentative, then there are all the possibilities can be in the room. When we are pressured to go too quickly into certainty, we miss things, right? So we miss the true or accurate meaning of the behavior. What is a child trying to solve through this behavior, right? Within the family relationship and the context that they live in, right? The child is trying to communicate something through this behavior. Yeah, that behavior is really inconvenient for the classroom. Really inconvenient. It's not helping mom at all. I'm sorry, but the child is trying to communicate something, right? So so those things are coming to my mind.
I hope I'm answering the question the right way, because what comes to mind when we kind of ask this and what Haruko's kind of been talking about is a curiosity too. I try to make an environment that is just relaxed and natural for the family. So, I mean, during my evaluations, we could be playing a game, we could be reading a story. I want engagement. I want to offer opportunities of engagement to see the receptiveness and what the family naturally kind of gears towards. A kid might not want to read a story. Maybe they want to play a game instead. Maybe they want the story and not the game. So I kind of try to get just a natural environment that is like, hey, I've got plenty of things to play with, things to do. Do we color? Look, it's a learning style that the children and the family like identifying what works for them, what's more natural for them, and not super stiff and kind of like corporate feeling for them. I want them just to come in and hang out, to chill and relax and have this conversation. And it just be natural too, and the curiosity. Hey, kiddo, what do you want to do today? Right? Are we reading a book? Are we playing a game? And by doing that, you get a lot of great observations too, and be curious, ask more questions about it, right? Like when you're reading a story, you can get a lot of developmental questions kind of answered from that story reading. You can get it from playing a game too. Physical games. I love moving with my kids. Like, let's see that development there too. How does the parent respond to the child's behaviors when we're playing a game? You know, like we get a lot of natural play in session that offers great observations and opportunities to ask questions.
Well, Laura, I don't know if you have burning thoughts that you feel the need to share, but we are coming to the close of our provider spotlight. If we could just give a big round of applause or hearts for Haruko, Haley, and Laura, being willing to be brave, showing up today, sharing their perspective and experiences. We're so appreciative to the three of you. And we're so appreciative to all of you who are in attendance with us. We hope that this was a valuable opportunity, that there was something that sparked your interest, that sparked your curiosity, that left you feeling like, maybe I don't know everything, or maybe I feel like I'm on my developmental journey to learn more. So we will follow up with an email that will have the recording from this, as well as the links to the other past spotlights that we've done. Some are recordings, some are slides. And again, just want to say thank you so much for being with us today. Christine and I will hang on for a few minutes afterwards if folks have questions.